welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Meagan, Macalalag, who is a PGY2 critical care resident at UW Health. Today, she'll be presenting a journal club on nebulized versus IV tranexamic acid for hemoptysis, which is a pilot randomized control trial.
First, I just want to disclose that I have no potential conflicts of interest related to the content of this presentation. I would also like to note that this presentation will discuss the off-label use of tranexamic acid. So hemoptysis is the expectoration of blood from the lower respiratory tract, originating from the pulmonary arteries or the bronchial arteries. And depending on the anatomical source of the bleeding and the underlying cause, presentation of hemoptysis can range from light streaks of blood in expectorated sputum to large amounts of frank blood. The degree of severity is defined, categorized into two separate categories. We have non-life-threatening or non-massive hemoptysis and life-threatening or massive hemoptysis. So massive hemoptysis is the most severe form of hemoptysis. Historically, the two have been differentiated based on the volume of blood that's expectorated, but because the volume of blood expectorated is often difficult to measure or estimate, and oftentimes there's no differentiating volume that's ever been agreed upon in the medical literature, massive hemoptysis is now defined as any degree of hemoptysis that causes significant clinical consequences, such as hypotension or respiratory failure due to airway obstruction. Usually, it can originate from the pulmonary arteries or the bronchial arteries, and although the pulmonary arteries do supply 99% of the blood flow to the lungs, the bronchial arteries carry oxygenated blood to the lungs at a pressure 6 times that of the pulmonary arteries. So oftentimes with massive hemoptysis, it's therefore more likely to originate from the bronchial arteries. Hemoptysis is difficult to diagnose given the multitude of etiologies, but with the two different categories based on the severity of hemoptysis, non-life-threatening and life-threatening. Some common etiologies for non-life-threatening hemoptysis include acute bronchitis, bronchiectasis, malignancy, and pneumonia. Whereas for life-threatening hemoptysis, some common etiologies include tuberculosis, aspergillosis, bronchiectasis, and malignancy. I do want to note that for a majority of hemoptysis, etiologies are often cryptogenic, where the origin is unknown. Now, the management of hemoptysis depends on the severity of the bleeding as well as the underlying etiology, but in many cases, treating the underlying cause of hemoptysis will resolve symptoms. So etiology-specific treatments such as antibiotics or antifungals. Other treatment modalities include antitussives, antifibrinolytics, surgery, and interventional procedures, commonly bronchial artery embolization, which is usually the treatment of choice for massive or recurrent hemoptysis. So usually after treating the underlying cause of hemoptysis, if bleeding does persist, additional intervention may be required. For this presentation, though, we will be focusing on antifibrinolytics, specifically tranexamic acid. So tranexamic acid is a potent antifibrinolytic agent. It is a synthetic derivative of the amino acid lysine, which blocks the interaction of plasminogen with the lysine residues of fibrin and exhibits an antifibrinolytic effect. The only FDA-approved usages for tranexamic acid is for heavy menstrual bleeding and tooth extraction in patients with hemophilia. So as noted previously, the use for hemoptysis is an off-label indication. Common dosage forms are oral tablets as well as intravenous solution, and the antifibrinolytic effect is seen at a plasma concentration of 10 to 15 milligrams per liter. Common adverse effects include headaches, abdominal pain, back pain. You can also see immediate or delayed hypersensitivity reactions, seizures and myoclonus, ocular effects. This can be vision color changes or just vision impairments, as well as thromboembolic events such as DVTs or PEs. Now, there are many case reports and case series that evaluate the use of intravenous and nebulized tranexamic acid for hemoptysis of various etiologies. There is also a randomized control trial, which is by Wand and colleagues, which was published in Chest in 2018. And this looked at inhaled tranexamic acid for hemoptysis treatment and really to evaluate the effectiveness of nebulized tranexamic acid for hemoptysis. So as mentioned, this was a double-blind randomized controlled trial. There were a total of 47 patients admitted with hemoptysis of various etiologies. Some notable exclusions were if patients had massive hemoptysis or if they were hemodynamically or respiratory instability. The interventions were nebulized tranexamic acid at 500 milligrams 3 times a day versus placebo, which was normal saline, 0.9%, 5 mLs, also 3 times a day. For the primary outcome, so it looked at complete resolution of hemoptysis within 5 days. And it's noted that more patients in the tranexamic acid group achieved resolution of bleeding within that 5 days of admission. Tranexamic acid was also associated with a significantly reduced amount of expectorated blood starting from day 2 of admission. For secondary outcomes, they looked at need for interventional procedures, and there were actually no patients in the tranexamic acid group that required interventional procedures to control the bleeding. And then the hospital length of stay was also notably shorter in patients who received tranexamic acid by about 2 days. Also important to note that in this study, the rate of recurrent hemoptysis at 1 year was significantly lower in the tranexamic acid group, but there were no significant differences in mortality between groups. So this randomized control trial really highlighted that nebulized tranexamic acid is effective and safe to control bleeding for patients admitted with non-massive hemoptysis. So going into the journal article that I will be reviewing today, which is Nebulized versus IV tranexamic acid for hemoptysis, a pilot randomized control trial by Gopinath and colleagues, published in CHEST in 2023. So this study looked at comparing the use of nebulized tranexamic acid and intravenous tranexamic acid among patients with hemoptysis in the ED. This was an open-label, parallel, pilot randomized control trial, and it was really done to explore the feasibility and potential efficacy of nebulized tranexamic acid for hemoptysis. This was a single-center study done at the All India Institute of Medical Sciences in New Delhi, India, and this was conducted from July 2019 through December 2021. And it was based in the ED of a tertiary academic medical center. So this academic medical center managed about 450 patients daily in their ED. It's important to know that all patients were enrolled from the ED only. Also, their average ED disposition time was about 36 hours. So all patients who had active hemoptysis, irrespective of the amount of expectorated blood, were included in the study if they were age 18 years and older. And active hemoptysis was defined as blood in the sputum in the last 30 minutes. So if they presented to the ED with active hemoptysis or found to have active hemoptysis on evaluation, they were included. Those who were hemodynamically unstable or required immediate interventional procedures or mechanical ventilation were then excluded, as well as patients who had massive life-threatening hemoptysis. Also, if they had known hypersensitivity to tranexamic acid or had prior treatment with tranexamic acid, they were also excluded from this study. So they did a block randomization to see which patients would receive tranexamic acid via nebulization route or intravenous route. Patients and clinicians were not blinded from the assignments, but the statisticians were blinded. So the IV dose was 500 milligrams intravenous tranexamic acid and was given on arrival and 3 times daily. And then for the nebulized tranexamic acid, it was also 500 milligrams on arrival and 3 times daily. Discontinuation of tranexamic acid occurred either at 72 hours of ED presentation, upon discharge from the ED, or when definitive intervention was required, whichever came earlier. So for the primary outcome, we looked at cessation of bleeding in patients presenting to the ED with active hemoptysis at 30 minutes following tranexamic acid administration. So cessation of bleeding was defined as 0 milliliters at 30 minutes following the administration of tranexamic acid. Secondary outcomes looked at the reduction in volume of hemoptysis at 30 minutes and at 6, 12, and 24 hours, as well as the need for interventional procedures and adverse effects of tranexamic acid administration. So baseline characteristics and outcomes were compared between groups by using parametric t-tests or non-parametric Wilcoxon rank sum tests for continuous data depending on distribution, as well as chi-squared or Fisher exact tests for dichotomous data depending on the sample size. Also notable that they did a two-sided p-value less than 0.05 was considered statistically significant, and they did a chi-square test to examine the relation between the route of nebulization and the cessation of bleeding. as well as a bidirectional ANOVA to analyze the effect of nebulized and intravenous tranexamic acid on controlling hemoptysis. So there were 190 patients that were screened for eligibility. 80 patients were excluded for various reasons, including massive life-threatening hemoptysis. Again, if they required mechanical ventilation or immediate interventional procedure, if they had known hypersensitivity or prior treatment with tranexamic acid, or if they declined to participate. So 110 patients in total were included, and it was divided 1-to-1. So 55 patients were allocated to the nebulization route, and then 55 patients were allocated to the intravenous route. It's important to know that all patients received their allocated intervention, and no patients were lost to follow-up or inappropriately discontinued intervention. So these were the baseline characteristics of the study population. Mean age was around 46 years, and majority of patients were male, but it's notable that there were no statistical differences in baseline characteristics. Now, looking at some history and physical examination characteristics, do want to point out that there were a few patients who were on warfarin and also antiplatelets. For the purpose of this study, antiplatelets and anticoagulant medications were stopped until bleeding cessation. There were also a significant number of patients who did have a history of tuberculosis. Now, for diagnostic characteristics, we can see that majority of the patients, their diagnosis was tuberculosis, with more than 70% in each group. And for this study, they considered the cause of hemoptysis to be the ED working diagnosis that was made by the treating team. We can also see that there is a higher number of patients who their diagnosis was allergic bronchopulmonary aspergillosis. So with tuberculosis as well as aspergillosis, this could be attributed to the geographical variation, theirs being a tertiary referral hospital. So the primary outcome did look at hemoptysis cessation at 30 minutes following a tranexamic acid administration, and it was significantly higher in the nebulization arm. So we can see that 40 patients who received nebulized tranexamic acid did have hemoptysis cessation at 30 minutes, with 28 patients who received intravenous tranexamic acid had hemoptysis cessation at 30 minutes. And this was statistically significant with a p-value of 0.0019. Again, cessation of hemoptysis being defined as 0 milliliters at 30 minutes following tranexamic acid. For secondary outcomes, they looked at the volume of hemoptysis at 30 minutes, at 6 hours, at 12 hours, and at 24 hours. I do want to note that the amount of hemoptysis pre-treatment was similar between both groups. So we can see here that the volume of hemoptysis was reduced significantly in the nebulization arm at all time periods of observation. And then looking at management and disposition from the ED, fewer patients in the nebulization arm required bronchial artery embolization and thereby had higher discharge rates from the ED. And this was because for patients to receive a bronchial artery embolization, this could only be performed following admission. So no patient who was discharged directly from the ED underwent any interventional procedure or revisited the ED with rebleed during the 72-hour follow-up period. Also want to note that there were no surgical procedures that were performed in either group. And there were also no major adverse effects that were noted in any patients. There were 2 patients, one of whom had chronic obstructive airway disease that did have asymptomatic bronchospasms, but these resolved following beta agonist nebulization. So the authors concluded that there were significantly greater reductions in expectorated blood volume when patients received nebulized tranexamic acid. And there were also fewer patients who received nebulized tranexamic acid that required interventional procedures, specifically a bronchial artery embolization. They also concluded that there were significantly less patients who received nebulized tranexamic acid that required admission for the management of hemoptysis. So this was the first RCT, or randomized control trial, that compared nebulized to intravenous tranexamic acid for hemoptysis. We did utilize the prior randomized control trial by Wand and colleagues, and so the dosing of tranexamic acid did reflect those previous studies. Their exclusion criteria was also reflective of that randomized control trial that evaluated nebulized tranexamic acid compared to placebo. And they were also looking at clinically relevant outcomes. For limitations of the study, the time period was during the COVID-19 pandemic, so there were multiple interruptions because of restrictions on the use of nebulizers during that period. It was also a single-centered design, which limits generalizability, and it is an ED-based study and in a resource-limited setting, so they didn't have any access to an electronic health record. All data collection was done manually from physical files. And then also noting that because it's an ED-based study, patients were followed up for 72 hours to note for any interventional procedures or adverse events or rebleed, but the amount of hemoptysis was only noted for that 24-hour period because it was based in the ED. So some key takeaways: nebulized tranexamic acid may be more efficacious than intravenous tranexamic acid in reducing the volume of hemoptysis and need for interventional procedures. Nebulized tranexamic acid is a less invasive route of administration that can be easily and rapidly initiated compared to the intravenous tranexamic acid. But evaluation of outcomes beyond the ED and extended follow-up periods are warranted. For this study, they did not monitor patients for seizures or any neurotoxicities, which are known complications of tranexamic acid. This was because it was conducted in the ED setting. So again, follow-up was only for 72 hours. Also, didn't assess for VTE complications, which may occur after weeks or months. So this could not be captured. So extending that follow-up period would be warranted. Further research is needed to optimize really the dosing of nebulized tranexamic acid and really evaluate the pharmacodynamics of that route. But based on this limited evidence, nebulized tranexamic acid may be a useful tool in the management of hemoptysis. And then lastly, I would just like to thank my preceptor, Jeff Fish. And with that, I would love to hear your thoughts and happy to answer any questions you may have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.